To record to the Okay. All right. Hi, everyone. Thank you so much for coming out today to our Insight to Impact Module 3, Treatment and Chemotherapy. We're really excited to have Dr. Abdul Farouk here to speak for us today. I'm just going to introduce him. So Dr. Abdul Farouk completed his medical degree at Aga Khan University Medical College in Karachi, Pakistan, and subsequently completed his postgraduate training in general internal medicine and medical oncology under the Royal College of Physicians of Ireland. Dr. Farouk has gone on to complete a 2-year GI oncology fellowship at the Princess Margaret Cancer Center in Toronto between 2022 and 2024, with a focus on gastroesophageal and HPV malignancies. Dr. Farouk was a part of several research projects and was on the ASCO Cancer Conquer Merit Award in 2023, as well as the Hold'em for Life Oncology Fellowship Award in 2022. He has had presentations at national and international meetings, as well as multiple publications in peer-reviewed journals. Dr. Farouk has an interest in treating gastroesophageal and HPV malignancies. He has recently started a new role as an attending medical oncologist at the Nova Scotia Cancer Center and assistant professor with the Department of Medicine at Dalhousie University in Halifax, Nova Scotia. So thank you so much for being here today, Dr. Farouk. We're really excited to have your presentation. And without further ado, I will hand it over to you.
Hi, thank you. Thank you very much for allowing me to be a part of this session, and thank you for that introduction. So I'll essentially share my presentation. Can you see that presentation now? Yeah.
Sorry, yes, we can. Sorry, my unmute wasn't working. Yes, we can.
Perfect. Welcome everyone, and this is a session as part of a 10-part learning series in covering key topics in pancreatic cancer. And this session is module 3, with a focus on chemotherapy. Thank you for that introduction. My name is Abdul Farouk, and I'm an attending medical oncologist at Nova Scotia Cancer Center. I did my fellowship at Princess Margaret Cancer Center, and I was a part of the McCain Pancreatic Cancer Clinic. I'm also treating pancreatic cancer patients as part of my role here, and part of my research was on pancreatic cancer genomics as well. So our learning objectives today are, first of all, to understand the purpose of chemotherapy in pancreatic cancer treatment, learn about common chemo drugs and their side effects, and then know what to expect during treatment and how to manage side effects. So moving to kind of our first objective, what's the purpose of chemotherapy in pancreatic cancer? And I think if we just step back slightly, to just say, what is cancer itself? So cancer basically consists of these deranged cells that are no longer adhering to the roles and the limitations that a normal tissue would usually have. So our normal tissues are governed by strict boundaries into how much they can grow, how much they can divide, and how much they can replicate themselves in their lifetime. And essentially, cancer cells are able to free themselves from those constraints. So this is from this landmark paper called Hallmarks of Cancer, which initially came out in 2000 and then subsequently has had a couple of iterations. And it looks at all the different ways that a cancer cell is able to grow and replicate the way that it does. And there's a few different ways and a few different abilities that a cancer cell has that allows it to grow the way that it does. So one of those is that it is able to proliferate, unchecked. Usually there are limitations in how many times a cell can replicate and divide, and there are limitations in how much it can grow. There are growth suppressors that tissues have to make sure that a cell or tissue does not grow or replicate or divide beyond a certain level. And a cancer cell would be able to have sustained proliferative signaling It would be able to evade those growth suppressor signaling that it gets. Usually, our immune system also has abilities to target these cells and kill them. And a cancer cell is also able to get abilities to hide itself from being recognized by the immune system and then avoid being killed by them. And then as it grows, it also gets um, increasing abilities to invade and to cause metastasis. It gets access to the body's vasculature to get more nutrients. And then it changes itself as it goes along to get more and newer abilities as well. So if you really want to kind of divide it into two or three different headings, you can characterize all of these abilities into abilities to grow, abilities to prevent itself from being killed, and abilities to spread itself more, and then also to change and gather new mutations as it goes along. Pancreatic cancers are similar. The vast majority of pancreatic tumors are adenocarcinomas. Um, and cancer is caused by either inherited or more likely acquired mutations in cancer-causing genes. And pancreatic cancer is also usually harbors genetic alterations which affect signaling pathways. There are some of these are more well defined. So, for example, we know that a large majority of pancreatic cancer patients would have a mutation in the KRAS gene. And the KRAS is part of the RAS pathway, which looks at cell regulation. There's also inactivation of tumor suppressor genes. So genes that are designed to make sure that a tumor does not grow and divide, the cancer is able to inactivate those. When we look at how to treat cancer in general, it can either be systemic therapy or usually non-systemic options such as radiation therapy or surgery. And in systemic therapy, there's a few different types. You can have chemotherapy, hormonal therapy, targeted therapy, or immunotherapy. But for the purposes of pancreatic cancer, the mainstay of our treatment is chemotherapy. Um, so moving to chemotherapy, first of all, what is chemotherapy? So chemotherapy uses powerful or strong drugs to kill cancer cells. So these are systemic agents. So they can either be given IV or sometimes they're given as pills. But for the majority of pancreatic cancer patients, their treatment is intravenous. Um, Although there is one occasion where sometimes pills are used if you're doing a combination of chemotherapy and radiation, which is not done very often, but it can sometimes be a modality as well. How does chemotherapy work? So, as I've said, cancer cells grow, and there's no real way to kind of limit their growth. Chemotherapy disrupts that growth and leads to their death. However, healthy cells can be affected too, which can cause side effects. So chemotherapy works by affecting cells in this process called the cell cycle. So the cell cycle is a process where a cell, any kind of healthy tissue as well, goes through these different phases in order to be able to kind of replicate and divide. During this process, they grow in size, they make copies of their genetic material, and they divide to form new cells. And it's at that point, that process of replicating their DNA and division of their cells, that they're more vulnerable. And it's that process that chemotherapy tends to try and target. So really, I mean, chemotherapy is disrupting these cancer cells, particularly affecting their DNA. So if you have an overview of the different ways that chemotherapy would kill tumor cells, it would be by some of them would damage the DNA, so that those agents are called alkylators. They can prevent the DNA from being made in the first place. So that's antimetabolites. They interfere in some way with DNA replication, or interfere with microtubule function, which is also needed for DNA replication and cell division. So this diagram tells you about the cell cycle again, but then there are different kinds of chemotherapy affect the cell cycles at different points in the whole process. While alkylating agents, for example, can affect throughout the whole process. So you can categorize different chemotherapies into different types based on their mechanism of action. And some of the chemotherapies that we use in pancreatic cancers are a part of this as well. So a platinum agent such as oxaliplatin would be an alkylator-like agent. 5-fluorouracil, which is very much used in FOLFIRINOX, is an antimetabolite. Taxanes, such as nab-paclitaxel or Abraxane, which is a part of the chemotherapies that we sometimes use, is also it basically affects the microtubules, which again is a part of DNA replications. And irinotecan, which also we used as part of the FOLFIRINOX regimen, is a topoisomerase inhibitor, which again is used quite a bit. So moving to what is the goal of chemotherapy? So there's a few different ways that we can use chemotherapy. First is to shrink cancers so they can be removed by surgery. So you can use them to control cancer if surgery is not possible, and aim to reduce pain and other symptoms from a cancer itself. And then there's one other mechanism that you can use, which is you can use chemotherapy to reduce the risk of the cancer coming back if you've had resection of your tumor. So when is the chemotherapy used? You can use it before surgery or neoadjuvantly to shrink the tumor. You can use it after surgery or adjuvantly to prevent the cancer from coming back. And you can use it in the palliative setting when surgery is not an option, and you're trying to make sure that you're controlling symptoms and controlling the cancer for a block of time. So when I'm trying to understand pancreatic cancer, I find it helpful to visualize it into these different categories rather than stage 1, 2, 3, or 4. So when pancreatic cancer patients present, they present in one of these different categories. So one is the tumor is resectable. So that's a very small tumor that's not really impacting any of the vessels, and it can be surgically resected up front. So quite a lot of these patients would go straight to surgery. There is interest in looking into whether giving some chemotherapy before surgery might improve outcomes, but the standard at present is still to proceed to surgery in some of these cases. The next is borderline resectable. So these are patients who have a slightly larger tumor and it's impacting the blood vessel in some way. It's contacting the blood vessels around the pancreas. And the thought is that if they get some chemotherapy up front, that can shrink the cancer a bit. It can pull the cancer away from the contact that it has with the blood vessels, and then make surgery more possible and more feasible. So quite often these patients would have neoadjuvant chemotherapy to try and reduce the cancer size and also to change the way that it is interacting with those blood vessels to make the surgery more possible. Then we have what we call locally advanced cases, and some of these can have more significant interaction of the tumor with the blood vessels. And essentially that interaction can sometimes make it very difficult for us to proceed with surgery. So you start off with chemotherapy in these cases, you see how they respond. If there is a remarkable response, sometimes, it's possible that the tumor might shrink away from the blood vessels enough for surgery to be possible. But it is also possible that these can be unresectable, and you are not able to kind of change the interactions with the blood vessels. And then you have metastatic disease. So you have the primary tumor, but there's also areas of disease elsewhere. Quite often, this is the liver. And in those cases, systemic therapy or chemotherapy is the mainstay of therapy. And our aim is to control the cancer for a block of time, and also to make sure that we prevent it from growing further, and that helps with quality of life and symptoms as well. So when we're looking at chemotherapy in pancreatic cancer, you have a few different settings where these agents are used. So one is the neoadjuvant setting before surgery, and the goal again is to reduce the cancer size and also to alter the interaction that the cancer has with the blood vessels to allow the surgery to take place. There's the adjuvant setting where the cancer has been resected, but you want to reduce the risk of the cancer coming back. And that's why you give adjuvant chemotherapy or chemotherapy after the surgery. And then there's the palliative setting where the cancer is either unresectable or metastatic, and the goal of your chemotherapy is to keep the cancer under control for as long as we can, and also to improve quality of life while the cancer is under control, and that also helps in extending survival as well. So moving on to our second objective, learning about common chemo drugs and their side effects. So the common chemotherapy drugs that we use quite often in this disease, the first agent is gemcitabine. So gemcitabine is a drug that's been used for quite a while. It was one of the first drugs that showed some activity in this disease. Nowadays, it would be used usually in combination, although sometimes if somebody would not be able to tolerate other agents, you can use gemcitabine on their own as well. Then comes FOLFIRINOX, and FOLFIRINOX is one of our more robust chemotherapies. So it's a combination of three different drugs together. So oxaliplatin, irinotecan, and 5-fluorouracil. And it is used in a few different settings. So for example, in the adjuvant setting, FOLFIRINOX is what I would use. In the neoadjuvant setting as well, if the patient is well and fit enough, I would usually use FOLFIRINOX. And it's used in this 2-weekly cycles. So essentially, it's also a drug that needs a central line. So you need a portacath or a PICC line to be in place for us to proceed with FOLFIRINOX. What happens is that some of the chemotherapy is given on the treatment day, and then the patient goes home with a small bottle's worth of chemotherapy that goes in over 46 hours or 2 days, and then it is disconnected, and the whole process starts again after 2 weeks. So it's a 2-week cycle. So FOLFIRINOX has more side effects as well, anecdotally at least. But it's used quite a bit in our arsenal. The other agent that we use quite a bit is gemcitabine and nab-paclitaxel. It's also one of our more commonly used options. It's used in a couple of different regimens. So one is to give it weekly for 3 weeks, and then you get a week off, and the whole cycle is 4 weeks. And sometimes some clinicians would give it every 2 weeks, and that makes it easier, more tolerable, and there's some evidence to say that there's really not much of a reduction in efficacy. And then one of the options that is being studied and is coming up is liposomal irinotecan. which is like folfiridox being used in combination with 5-fluorouracil and oxaliplatin. It's essentially a cousin of irinotecan. So that's one of the newer treatments that is being studied and is being used as well. The mainstay of therapy that I would, in general, use is folfiridox and gemcitabine and nab-paclitaxel. So chemotherapy side effects. Chemotherapy damages rapidly dividing cells. So that's cancer cells, but there are parts of our body that are more rapidly dividing as well. So, for example, the GI tract. So the common side effects that you can get are things like fatigue, alopecia, mucositis, nausea, diarrhea. One of the significant side effects to always look out for is febrile neutropenia. So essentially what that is a combination of low neutrophil counts. So your white cell counts are low. That makes you more prone to infection. It also increases the chances of bacteria which are in our, are on our body or in our mucosa to actually, translocate into the bloodstream as well and cause an infection. Essentially, if you have a temperature above 38 when you're on chemotherapy, that's an emergency. So you have to go to the emergency department. You don't call anyone. You just go to the emergency department because the problem with a temperature is you don't know if you're neutropenic, if your neutrophil count at that point in time is below 1, for example, or could be, can be as low as 0.1. And if you wait overnight, for example, for that and say that I'll call somebody in the morning, in that time, it could have progressed to the point where when you kind of come to anyone in the morning, your blood pressure is already low, you're vitally not stable. So it's an emergency. If you get a temperature above 38 when you're on chemotherapy, you have to go to the emergency. You don't call anyone, you have to go to the emergency department. So, and what they will do is they'll do cultures, they'll start you on broad spectrum, strong antibiotics, and they'll typically liaise with the oncology team as well. So there are other kind of unique toxicities which are particular to certain chemotherapy. So for example, neuropathy is something that is quite common in the regimens that we use, more so with oxaliplatin, but also with nab-paclitaxel. And then, you could get coronary vasospasm with 5-FU, which I'll just come to as well. So common side effects. So most patients with chemotherapy will get fatigue. You can get fatigue, tiredness. It can affect your appetite. Patients can get weight loss. Particularly pancreatic cancer has a tendency to itself cause weight loss, and then the chemotherapy can add to that as well. It can affect your hair. It can cause hair loss, and that's different between different regimens. So for example, for FOLFIRINOX, that your hair can thin, they don't necessarily go. For gemcitabine nab-paclitaxel, it's quite possible that your hair will go. It can cause ulcers in the mouth, but we can give you mouthwashes to help with that. It can cause nausea and vomiting, but we give you strong antiemetics for that. And we have guidelines for each chemotherapy regimen around what kind of anti-nausea medications to use, and there's scope to actually escalate on those as needed as well. So nausea and vomiting and our ability to kind of control it is a lot better now than it would have been perhaps a couple of decades ago, although it still remains a significant issue. It can affect your bowels, sometimes cause constipation, but mostly cause diarrhea. But we can sometimes help with giving you medications for that as well. It can affect your blood counts, as I said, make you more prone to infections. And, if your temperature goes above 38, that's an emergency. You have to go to the emergency department. It can affect the other blood counts as well. So I suppose your hemoglobin, so that we have to keep a close eye on that. And then your platelets, which make you clot. So they can go low, and that makes you at higher risk for bleeding. So that's something that we have to keep a close eye on when you're on chemotherapy. And then for pancreatic cancer, the regimens that we use, peripheral neuropathy is something that is common to both the regimens that we would typically use. More so, however, with oxaliplatin. So there are certain side effects that are particular to certain regimens and certain agents. So, for example, as I said, peripheral neuropathy is present for both the chemotherapy types, but it's much more so with oxaliplatin. And there's also cold intolerance. So essentially, if you get exposed to the cold, if your hands get exposed to the cold, there can be discomfort and numbness. Um, and peripheral neuropathy is, or numbness in your hands and feet is something that we keep a very close eye on when you're on chemotherapy. If it starts to become much more permanent, if it starts to affect your ability to do anything, we typically have to either reduce or stop the oxaliplatin. 5-fluorouracil has some particular side effects that are associated with it. So there's this rare risk of coronary vasospasm. So what can happen is that it happens when you're on that 5-FU bottle and the 46 hours that you're at home. So if you get chest pain particularly when you're on that bottle, but not necessarily only then, that's also an emergency. You have to go to the emergency department because that's essentially like a heart attack. So you have to go to the emergency department. Typically, they would have to disconnect your bottle and they have to manage that event. There's also this rare risk from 5-fluorouracil with what's called a DPYD deficiency. Essentially, what that means is that there's a very, very small percentage of the population that has an inherited inability to metabolize 5-fluorouracil. So what that and typically don't test for it, but there are some centers that do some testing for it, but it's not clear to what extent you're able to test for all the different mutations that there are. And essentially what that manifests itself as is that you have a lot of side effects with the first dose that you get of 5-fluorouracil. So there's always that risk associated with that. And then 5-fluorouracil can come up with very strange, very, very rare, but very strange side effects sometimes. You can get encephalopathy sometimes, for example. Irinotecan, as part of the FOLFIRINOX, is notorious for diarrhea and GI upset and associated abdominal cramps. So a lot of patients on FOLFIRINOX or irinotecan of any kind can get diarrhea. There are ways to kind of try and control it. So I suppose one of the ways sometimes that we use is to use Imodium, using 2 tablets with the first episode and 1 tablet with every subsequent episode. But if you're needing 4 or 5 or more, it's probably kind of a good idea to either contact the oncology nursing line or to seek medical attention or go to the emergency department. The cancer itself, and pancreatic cancer, is unfortunately notorious for this. And the chemotherapies both predispose you to clots. So clots in the lung, clots in the leg. So if you get any sudden chest pain or sudden shortness of breath when you're on chemotherapy, you have to go to the emergency department because that could be a fairly severe clot in the lung. Similarly, if you get swelling, redness, pain in one leg more than the other, that could be a clot in the leg. You have to go to the emergency department. And there's a few different situations that I would always kind of try and counsel my patients that, they need you to go to the emergency department. You don't call anyone in those situations. So to kind of reiterate those, that's the temperature above 38, sudden chest pain, sudden shortness of breath, swelling in one leg, and then also if you're having diarrhea that's not controlled, and really any kind of really symptom that's severe and uncontrolled, sometimes you need to seek medical attention and possibly present to the emergency department. So finally, knowing what to expect during treatment and how to manage side effects. So it's a good point to introduce the role of a medical oncologist. So medical oncologist is a cancer doctor who plans and supervises your chemotherapy. They help you understand your cancer and your treatment options. And how do we decide what to use? So um, a lot of what we do is based essentially on one, we have guidelines, national guidelines, international guidelines. And then you have a lot of what we do, and essentially those guidelines themselves are informed by randomized controlled trials. So there are trials that would have looked at each of these chemotherapy regimens in comparison with other agents. And essentially, it's the benefit that's been shown in those trials that translates into our practice. And funding of regimens is also, also determines what we can use and what we cannot use. And then finally, we assess a patient on how they are, how much they would be able to tolerate in terms of chemotherapy, what comorbidities they have, and how that can affect the regimens that I could use. So, for example, if somebody is diabetic, already has a lot of peripheral neuropathy that affects a lot of peripheral neuropathy, for example, sways whether I'm able to use something like oxaliplatin or not. So typically what happens is that the initial presentation, I would do a history and physical, but I would review the patient's imaging, their pathology, their diagnosis, what stage they are, and where they are in whether they are resectable up front, are they borderline resectable? Are they locally advanced and unresectable? Are they metastatic? And then decisions regarding the treatment plan and the choice of regimen is made at that setting. And then there's a few different steps that you do during those consultations. One is if there's been a few weeks since the last scan that this patient has had, I would do a baseline scan to see how things are at this point while I start off on chemotherapy. I would do a baseline set of blood tests. I would do tumor markers, and I would tend to follow those tumor markers or the CA19-9 in general, which gives me a very gross sense of how the tumor is behaving. If they're on FOLFIRINOX, they need a central line, so they get a PIC or a portocath insertion that needs to be arranged before they start. Typically, quite often I would refer for genetic testing because the pancreatic cancer diagnosis itself can sometimes be enough in certain jurisdictions to refer for genetic testing to ensure that there's no BRCA mutation as a potential contributor to this, and also to send the tumor tissue for genomic sequencing if we are able to get at least some baseline genomic sequencing, such as BRCA mutations and mismatch repair, for example. And then once the treatment plan is set, usually before every chemotherapy dose or every other chemotherapy dose, the patient would be seen and they would need blood tests before every dose. And for example, taking just FOLFIRINOX as an example, that essentially, they're seen or their bloods are done, they proceed to chemotherapy. They get some of the chemotherapy on the day, and then they go home with a small bottle's worth of chemotherapy that goes in over 46 hours. They get disconnected, and then the whole process starts again after another 2 weeks. In that time, typically, quite often what happens is that the first 2-3 days are not the most significant in terms of side effects. It's day 4, 5, 6 sometimes that are more severe, where the patient starts to feel that their energy levels start to drop, their appetite starts to drop, they're spending a bit more time resting, or they have nausea, vomiting, or GI upset. And then quite often what happens is that the first few days are more difficult, and in the second week, they start to kind of get better in terms of their energy levels, their appetite, and they come back near to their baseline at around the 2-week part when they get another dose. So typically around every 8 to 12 weeks, I would want to do a restaging CT to see where we are, and see how things are in terms of response. And if it is a localized cancer with some response, I would link back in with the HPB surgical team to see uh, how they feel. It's quite possible that you need 3-4 months of chemotherapy before there's enough of a response for us to proceed to something like surgery. But it's just important to kind of have them involved in a localized, potentially borderline resectable case. If we run into a problem, I would expect more or less all of my patients to have some kind of an adverse event of varying degrees. There are certain ways that we can proceed. We can reduce the doses to try and prevent something like this from happening. The way that we calculate the doses for these chemotherapies is based on your height and weight. That gives me a body surface area, but it doesn't necessarily take into account how one person might metabolize the drug differently from other. If somebody is somewhat frail, I might start off with a reduced dose upfront, and then see how things go. There are guidelines in place that tells us, for example, if I want to reduce the dose, to what extent I should, in terms of dosing. Sometimes you calculate, once you have a bit of experience, you kind of calculate it based on the percentage from the full dose, and take things from there. Quite often we would delay the cycle by a week at least. Sometimes you need more. So if they've had a significant hospitalization, or if there's an ongoing infection, you would need to delay the cycle. And that's something that needs to be done. Sometimes it's important to make sure that the dose is such that you're able to give regular doses without interruptions. It's better to have a slightly smaller dose, but which you're able to give more regularly, rather than having an extremely large dose which the patient might not be able to tolerate. Sometimes, if we're running into a lot of trouble, you can think about abandoning therapy, assessing if surgery is possible or not, or you can change the regimen if there is a significant side effect. Although we try and work with the regimen itself and make changes in that if we can. What helps in managing side effects? So anti-nausea medication. So all of our regimens would have an antiemetic regimen assigned to it in general, based on the level of emetogenicity, or level of how much it's expected to cause nausea and vomiting. And then we give you anti-nausea medications to take if you need it, in between as well. So we have options there quite often. Pain, if the patient is experiencing pain, you have to be on pain control. So we generally use very small doses, but of very kind of active opioid pain medications such as hydromorphone quite often. But it's important to make sure that you're not in pain, when you're going through this. Sometimes if you had a significant, decrease in energy levels and appetite, and led to a significant deterioration, you can use something like steroids, for example, to improve your appetite, in short courses, just to kind of make sure that the patient improves, and we are able to kind of think about restarting. Nerve blocks are sometimes that you need for very, very severe pain. It would only be used if the pain is not really being controlled with standard pain medications. And yeah, some patients have a benefit from it, some patients do not. But in general, you would always have a nursing line or a phone number that you can contact us if there are any side effects that are difficult, and we would usually be able to make recommendations, along the way. So it's important to kind of use those resources because they're important. Can I have surgery and chemotherapy? So as we've discussed, some patients have chemotherapy before surgery as neoadjuvant. Some patients have chemotherapy after surgery as adjuvant. And these decisions are quite often made by the oncologist, but also in a multidisciplinary setting, with the surgeons and other members of the team as well. If you're unsure at any point, you can ask questions to try and understand. There's always a possibility for you to ask for a second opinion. You can always talk to your oncologist if you have any questions. And it's always important to have supportive care and issues handled along the way, and for us to make sure that your symptoms and pain are controlled, because that leads to improvements in quality of life, but also has an actual impact on outcomes as well along the way. So finally, chemotherapy is part of our treatment plans in a few different ways. We have several patients who are undergoing these treatments. So you can always talk to your care team and use resources such as the Great Scots Pancreatic Cancer Society to get support as well. Thank you.
Wow, thank you so much, Dr. Farouk. That was amazing. That was lots of really great information. Now we'd like to open up the floor for any questions. Feel free to either type them in the chat or to unmute yourself.
So I suppose in general, FOLFIRINOX and Gem/Nab-Paclitaxel is the standard of what we use. The only thing that I would say could be different in recent months, perhaps, is the NALIRIFOX. So NALIRI is, as I said, it's this cousin of irinotecan that is used. There's some evidence to suggest that it kind of did well against gemcitabine and nab-paclitaxel. There are caveats to that as well. So that might be being used in some US centers. But you see, it's difficult to interpret the data because there would be different opinions on this, whether it actually has much of a benefit or not. But I suppose, in terms of standard of care regimens, FOLFIRINOX and gemcitabine and nab-paclitaxel are what we use and would be standard of care. It's just that NALIRIFOX might be being used in some US sites. So essentially, the question is, about, so if the tumor is localized enough, you would go ahead with surgery up front, and do chemotherapy after surgery to reduce the risk of the cancer coming back. Once, it is somewhat borderline resectable, there's some element of concern around maybe rising tumor markers, etc. You would kind of pivot towards going towards chemotherapy first. I would generally tend to do scans every 2 months or so, once you've had, every 4 to 5 cycles, to see how things are responding. And, if there is a response, I would kind of liaise with my HPB surgeon. These are shared decisions that are made, and it depends on what the multidisciplinary team feels, in terms of whether it's the time to proceed with surgery at that point. Sometimes it needs 4 months, so I would do another scan in about 2 months later and just see where we are. But there's, how the tumor is behaving on the imaging, how the tumor markers are doing, which kind of gives us a broad sense of how things are going as well. All of that together, that helps us make that decision. That's a good question. I suppose you have to have a balance. Essentially, what I would say is that my own feeling always is that it's important for us to be able to give regular chemotherapy. So if you give a big dose and that knocks the patient out for 3 weeks or 4 weeks and delays their chemotherapy, I would say that it's preferable to have a slightly lower dose and but be able to give them consistent chemotherapy. We have to make changes in terms of doses all the time. And I would not necessarily feel that lower doses necessarily lead to lower efficacy. Um, I suppose my own feeling is it's important for me to give you regular treatment, which leads, and I suppose, as I said, we make these calculations based on your height and your weight, which gives a rough calculation of body surface area. It doesn't necessarily take into account any difference in your ability to metabolize the drug, different from somebody else's. So you always have to, tailor it to how you're doing, how you're responding, how you're able to tolerate. And always the aim is to make sure that you're able to proceed with chemotherapy while not really impacting your quality of life to a very severe extent. We don't want to make you miserable when you're on chemotherapy. It's important for you to have efficacy while still being, you being able to kind of continue on with most of your activities. No, there would be differences. The regimens used are slightly different. It's a relatively small percentage of our cases. It's slightly different disease. Not really. No. So I suppose, from a, you know, for efficacy for the cancer, I would use the chemotherapy. You use supportive medications, but I suppose there isn't anything necessarily that I can think of that I would uh, give alongside the chemotherapy as such, etc. One, I'm not sure how efficacious they are because I'm not sure if they've been tested in a robust randomized controlled trial. But also, what I'm worried about is I don't know how they impact some of your organs. So, for example, um, some of the issues with some of these supplements, etc., is that I don't know. So, if your liver function starts to go off, I don't know if that's the supplement that's causing that or is that the chemotherapy. So it impacts my ability to be able to continuously kind of give, or continually give chemotherapy. So I, in general, tend to suggest not to kind of take those because I feel that impacts my ability to give systemic therapy. There's nothing that I can kind of suggest. I know that it's a fairly robust kind of regimen in its own right, the 12 cycles. In general, you kind of move to a surveillance phase. What I would say is, just make sure that you're having a healthy diet. In general, if you have any new symptoms, contact your oncologist or your surgeon, whoever's kind of looking after things, just so that they're able to kind of review you earlier, do a scan earlier, do blood tests, take a look at your tumor markers, to make sure if there is anything that's identified. Other than that, it's very difficult to kind of say if there's anything. There really isn't anything that is standard of care in terms of maintenance. So I suppose, the thing with neuropathy is that um, it accumulates as you go along. So what we're trying to do is trying to kind of, keep a very close eye on it. Because generally what happens is that it is as I said, is cumulative. So in the first, few cycles, what would happen is that you would get a bit of neuropathy, but then it would be transient, and by the time they're due their next cycle, it would go away. It would be intermittent. It would be more kind of associated with the cold. As you go along and you've reached about 4 to 5 months, for example, particularly of Volfirinox, that tends to last longer, and then sometimes will become, it's there all the time. As long as it's not impacting your ability to do anything. So with the fingertips, it's not affecting your ability to do like small things like opening buttons, etc. That's grade one. Technically you can kind of continue on, and with the feet as well. But I suppose once it is around the cusp of being there all the time, what I would say is that that's the point that you would stop the oxaliplatin, because what you worry about is that, once it's more kind of there all the time, it can quickly kind of go into this phase where it's starting to affect your ability to do things as well. And and then you don't want to kind of affect the patient in that way. Generally, when you stop the chemotherapy, it can improve, but in the first year after, but it's difficult to say to what extent it will improve for each patient. And it's possible that patients can continue to have peripheral neuropathy. In general, there is, if you have painful neuropathy, you can give something like duloxetine, for example, to help with that. That's, it's an indication. Some patients have painful neuropathy, and that can help in that situation. If it's not painful neuropathy, it's just it's numbness, but it can affect you, particularly if it's affecting your ability to do things, or what we would call as grade 2 at least, right? That is harder to manage. Our hope is that it will improve as things go along, as time goes by after your chemotherapy, but there's no guarantee that it will improve and to what extent it will improve. And if it's not painful, there's not necessarily a standard guideline as to what you can do. Some patients would sometimes say, maybe using pregabalin or gabapentin, etc., for example, but I'm not sure to what extent that would benefit or not.
Okay, thanks.
Thank you. So there's this one question.
I'm so sorry. I didn't realize I was on mute. I'm so sorry. Thanks so much, Jill, for the question. So Manish said, my tumor has spread to duodenum opening 1 and 2. Next week, the surgeon is going to put in a duodenal stent. Is it something with this disease? And will I have any food restrictions for life after that? And will I be able to eat normally? Thanks much.
So unfortunately, pancreatic cancers, because of the place that they're in, they can quite often, you see, that's the critical part about pancreatic cancer, is that it's placed in an area where so many critical parts of the body kind of go through. So I suppose it's very close to the duodenum, and it quite often will invade into the duodenum. And that will lead to a duodenal obstruction, which can be very significant, very severe, and can cause a lot of nausea and vomiting, etc. So putting in a duodenal stent is very reasonable in that situation. So it definitely is quite possibly related to the cancer. That can, I suppose, they'll probably kind of trial you on kind of soft diet at first when you've had it. Usually patients are able to kind of tolerate most kind of diets. But I suppose, you put in the stent, but I suppose, it's worrying when that has happened, and you want to kind of try and do something to kind of control the cancer going forward as well.
Okay, great. And then Barbara said, thank you for this presentation. Given the very serious side effects of FOLFIRINOX, why do you recommend this therapy over gemcitabine and nab-paclitaxel for certain patients?
So in certain disease types, FOLFIRINOX is what has been studied and is the standard of care. So for example, if you're adjuvant, gemcitabine nab-paclitaxel has not been studied in that setting. FOLFIRINOX is the standard of care. Neoadjuvant, it's difficult to say, but FOLFIRINOX is typically what I would use. If some patient is borderline, I can use gemcitabine and nab-paclitaxel as well. So, essentially, really at the moment, these are the two options that we have. So I would kind of use, based on what your performance status is and what the setting is and what I want to attain. In a purely palliative situation, I would feel that those are comparable. So quite often you start off with gemcitabine and nab-paclitaxel, but then if there is at any point, for example, growth on your first line, you pivot to your second line therapy. And if FOLFIRINOX was not used in the first instance, it will be used in the second instance. Because that is it's one of the two mainstays of our therapy at the moment. Yeah, so I would say that some patients derive some benefit from Lyrica, so it's something that can be attempted. I'm not sure to what extent it will help. Duloxetine, for painful neuropathy is there's a clear indication for it. Pregabalin can be tried and to see if it helps. Adrenal insufficiency sometimes comes up. Usually, they're established on these steroid doses. You have to, I suppose, make sure that in times of any crisis that dose has to be increased. So if they're unwell, for example, their doses have to be increased of those steroids. It's not something that I would say that it has come up quite a lot, particularly in pancreatic cancer for me, but I've seen it with different malignancies here and there.
Okay, great. Are there any other questions that anyone wants to ask? Stephanie said, excellent presentation. Thank you.
Thank you.
Okay, that's great. Well, if anyone does think of any questions, please email them to me, and I can send them to Dr. Farouk and see if we can get you an answer there. My email is just aaron@craigscause.ca. Otherwise, Dr. Farouk, want to thank you so much for jumping in on this presentation. Oh, I see Nancy said that was incredibly helpful. Thank you so much.
Thank you.
So just want to thank you so much for jumping in and doing this presentation. It was a little bit short notice, and Dr. Farouk really saved the day for us here today. So I'm really grateful for that. Yeah, and thank you everyone so much for taking the time on the weekend to come here and enjoy the program. I'll be sending around a link with the quiz for the sort of learning outcomes. And then otherwise, hopefully everyone just enjoys their weekend. Oh, and Manish said, thanks, Dr. Farouk, for such an informative session. Jane said, thank you. Nadine said, thanks so much. So yeah, lots of really happy and grateful people here today. So
Thank you.
yeah, so thank you all so much again. Really appreciate it and hope everybody has a great weekend.